Very good afternoon. All are requested to please join the next scientific session. We are going to start very soon. And it's really a wonderful session which is aimed to discuss the topic of the facing the threats, resurgence of the troublesome pathogens which we are really facing. And without wasting much time, am I asked to, we can start the session? So without wasting much time, we would like to invite on the stage our next speaker, Dr. Madhvi Joshi. She is a scientist and Joint Director of Gujarat Biotechnology Research Center. Madam, please come on the stage. As we know, she is always ready for us like microbiologists. Whenever we are in dilemma, whenever we need to learn something, or whenever we are in confusion, she is always ready to give conclusion. So now, session to you, madam.
Thank you so much, Dr. Bhulpesh, and I once again thank the organizers for arranging this session for the conference, specifically Dr. Atul Patel and Dr. Harsh Joshwal. I am the odd woman out in this gathering, because most of you are the infectious disease specialists or medical doctors. And in contrast, I am a scientist. The scientist who works with the state government research center, and organizers really wanted to discuss, some of the back-end processes of the diagnosis in the infectious diseases, and that's why I was assigned with this topic, that is role of emerging technologies for early diagnosis of infectious pathogens from PCR to next generation sequencing. And we are a state government research organization located in Gandhinagar, and the strength of our center lies into genomics. So we do a lot of genome sequencing work, including that for infectious diseases in Gujarat. So when you talk about NGS, I'm very sure everybody sitting in this auditorium will recognize that this is a jigsaw puzzle. And similarly, when we want to decode any genome sequences, whether it is a human or any infectious diseases, it's like this, that the DNA which is there in a human, that is 3.3 billion base pairs. And if you take an example of the SARS-CoV-2, it is 30,000 base pairs. So you can just see the magnitude of difference. So finding the SARS-CoV-2 DNA from the human samples, it is again like finding a needle from the haystack, or even worse than that. So typically in NGS, what we do is we identify the target nucleic acid, whether it is DNA or RNA, and then break it into the reads, because the machine has some limitation. So then those reads are sequenced, so that is called as upstream. And then the second thing is a downstream, where these reads are like a jigsaw puzzle. Bioinformaticians are trying to solve them and trying to understand that what does it mean, or how to infer out of these reads. So we make some contigs, and then the contigs will become the final genome with a quality, and that helps us to do a lot of help in the management of infectious diseases. So some of the examples that I am going to discuss today are on the clinical genomes, how we take care of that. The genomics is also deployed to understand host-pathogen interaction, because it's not always the virus that affects the individual, but the individual's makeup also has an impact on the final outcome of the disease. Then some of the disease dynamics, how we can measure with the genomics technology, and environmental surveillance, and some other case studies. So GBRC, was given a responsibility of doing the SARS-CoV-2 genome sequence during the pandemic, and all of us sitting in this room have, somewhere worked on a front line as far as the SARS-CoV-2 disease was concerned. GBRC was the second lab in the country to release the SARS-CoV-2 genome on 17th April 2020. And from there onwards, we have sequenced now more than 14,000 genomes of SARS-CoV-2, and a lot of work, which were done for the management of the COVID pandemic. So that include host pathogen interaction, wastewater-based epidemiology, some microbiome analysis, and detection of the infectious diseases from the non-human host in case of zoonotic diseases, and some mutation analysis. So whenever we want to undertake any genome sequencing specifically for the infectious diseases, the main goal is to identify first the causative agent, that for instance SARS-CoV-2 is responsible for the COVID-19 disease. Second is, once you know the genome sequence, you can track how the virus is evolving, and based on that your diagnostics and vaccine strategies also change a lot. And sometimes, wherever you have a drug target, you could also understand how these mutations are altering drug targets, resulting into resistant viruses that we see in case of HIV. And also understand the dynamics of the disease in population, so on and so forth. So this is just the trajectory of how the SARS-CoV-2 genomes have been sequenced by now. So during the pandemic, you see this colorful picture, this depicts different lineages that prevailed during the SARS-CoV-2 pandemics from the Gujarat state, and you can very well identify some of the major lineages like that dominated, including Delta, Omicron, and then some of the recombinant versions like XBB and other. So we continuously do that. But with the help of genome sequencing, what are the other important information that we are trying to derive that enables public health decision? So one important aspect is the phylodynamic analysis, which means that each of these viruses we can track back and understand that how they originated. And we study using this technique that is called as phylodynamics. So the first 600 genomes that were sequenced from Gujarat in the SARS-CoV-2, we subjected them to phylodynamic analysis. Majority of these sequences were from Ahmedabad, Surat, Vadodara, and some other cities, as you can see. And whatever you see in the graph below, where you are looking at the reduction in the R0 value, that is where the lockdowns were imposed by the state government and the national governments. With the help of genomics, we were able to understand the disease spread or the dynamics of the SARS-CoV-2, that how many top lineages we could identify or the chains of infection we could identify. And we concluded that in the first wave of SARS-CoV-2, there were more than 113 different infectious introductions in our population, that is in Gujarat. And if you would see, the TMRCA, that is the time for the most recent common ancestor of the particular pandemic that we identified using our genomics data, was the April 17, 2022, with a standard deviation of 35 days. So if you reduce 35 days and try to correlate it with the first case in Gujarat, which was reported around 19 March 2020. So what I'm trying to tell you is that the genomics information can give us a very well aware, informed picture about how the diseases are spreading in the community. Second thing that we did was a genome-wide association study. This is also now published in the Nature in collaboration with the scientists from the Broad Institute of MIT and Harvard. So as I told you, that during the pandemic we observed that many of the people remained asymptomatic with just the loss of taste and smell. Many were succumbed to ICU BiPAP, and many remained lightly symptomatic, but they could recover. So what we did is that in our human genome, if I typically compare the sequence of two individuals, 99.99% it is same. So the variation of 0.01%, which is close to 33 lakh nucleotides, if you put it into the clinically relevant nucleotides, that comes to close to 8,65,000 alleles on the human genome, which talk us about how we respond to, say, drug or susceptibility to cancer or so many things, so on and so forth. So in this, what we did is that we enrolled total 507 COVID-19 patients. From that, symptomatic and those who remained asymptomatic. And further they were followed up into their final outcomes. So 96 could not recover and they were deceased, and 327 recovered individuals. And the key findings that you see from this analysis is that we were able to identify certain host factors which play a very important role in the disease outcome of these SARS-CoV-2 individuals. And some of them are the tumor necrosis factor 4 and 18 superfamily genes, which are also reported for the myocardial infarction. And I am sure, being medicos, you would have observed that how many of the patients, post-COVID infections, they succumb to myocardial infarctions. And many other genes related to, D-dimer formations and all those were found to be significant. Now, these are, all the medical doctors sitting here. In majority of the time, or I would say 100% of the time, whenever you have to talk about the clinical sample genomics, you would be taking only the clinical samples. But today, I just want to show you that beyond clinical samples, how you can use genomics for understanding the infectious disease. And that is where the role of wastewater surveillance comes into picture. Now, what is common? If you just look at this picture, all of you know that blood is a homogeneous representation of an individual's health. Similarly, whatever we are excreting in a day-to-day life that ends up into our sewage system, that also is a homogeneous representation of the community health. And we can measure this sewage for many of the pathogens and see that what all things are present in our community. This is the data I have taken from WHO's guideline on wastewater surveillance. If you look at any disease outbreak, what we are missing out is the second most pillar in the pyramid, that is all the infected individuals who remained asymptomatic. They never went to any clinical facilities, and those individuals are the major source sometimes into leading to transmission dynamics of the diseases which we are not able to capture. So, during the pandemic, September 2020, GBRC was the first institute in the country to establish 2 weeks of early warning in case of SARS-CoV-2. So, when you measure the COVID from the wastewater and compare it with the clinical cases, what you get is a 14 days of early warning, and that gives us a lot of time for public health action. Similarly, we continue doing that till today. And if you would see that the orange line in this graph, that represents, the clinical cases that we used to get from the government through the RT-PCR and other data, that was stopped once the WHO declared it end of pandemic. But you can still very well see that after that also many waves in the community came and went. And all of them we were able to track it for the SARS-CoV-2 lineages. So you can trust this tool even in absence of proper clinical data. Then third important thing is that this is the first incidence where we sequence the SARS-CoV-2 genome from the wastewater. And what you can see here in this table, that is, the third row that I have highlighted, that is a position at the spike protein in SARS-CoV-2, which is a 6 nucleotide deletion, a typical of the data. And if you look at the date, that is a sample collected in a Winzol, which is a treatment plant in Ahmedabad, versus the frequency, which is 57% in our population. So what does it tell us? The COVID wave in Gujarat for Delta started from March 21 onwards. And even in the February, we had this variant very well circulating in our community. So, wastewater surveillance using the infectious diseases can tell us a lot about the emerging variants. And then we thought of taking it beyond SARS-CoV-2. So now we have established the wastewater baseline data for all the viruses, all the bacteria, all fungi, all micro-eukaryotes for 25 different locations for 1 year in Gujarat. And I'm just going to show you some of the glimpses of the virus data that we have done. So as you can see that consistently we are able to detect around 400 plus RNA viruses and 300 plus DNA viruses from wastewater. This rainbow graph only represents the diversity of viruses that were identified across the year from one particular location. We have also tracked the seasonal variation of these viruses, that how individual viruses are changing over the season. And some of the pathogenic viruses like hepatitis A, influenza A, human parainfluenza 1 and 3, noroviruses, rotaviruses, we have also depicted the trend. And this data we will be now using for some of the modeling work to predict, the infectious agents circulating in the community. Now, as a clinician, you would ask that these are just the wastewater representations and how does it correlate with the actual clinical case scenario. So I'll just show you here that since we were continuously doing SARS-CoV-2 analysis, you can very well see that the next generation sequencing also was able to pick up the key waves that came during the same season and same time. So which means that the technology that we are deploying is provable. It is dependable and it is doable. And it is now I am happy to share from this platform that the same is going to be replicated in pan-India Indian SARS-CoV-2 genome sequencing network of the phase 3, which is established by Department of Biotechnology. So another important thing, when we talk about infectious diseases, we cannot only look at humans. We have to also look at the zoonotic diseases from the animal point of view. When they are infected, the mutations or the evolutions of the virus can change and it can bounce back to humans. So during the COVID-19 pandemic, we also checked a lot of animals with the help of Animal Husbandry Department for the presence of SARS-CoV-2, and more than 413 animals were tested, and out of that 23% were found to be positive for SARS-CoV-2, and some of the sequences from dog and other wildlife, including that from Asiatic lions, we have sequenced the whole SARS-CoV-2 genomes and submitted to international platforms. Another important disease with reference to Gujarat when we talk about infectious diseases was a very recent outbreak in Chandipura. Now there are many times challenges, because some viruses are high copy number viruses, some viruses are low copy number viruses for the infection. And it becomes very, very difficult to track them from the clinical sample. So in case of Chandipura, even from the RT-PCR positive samples, we were not able to get the full genome. So for that, we designed a specialized strategy that is an ASICON-based panel for the Chandipura virus sequencing, and this is the glimpse of that. With the help of our newly developed technology, we again sequenced Chandipura virus genomes from the infected individuals, and this is how the entire genome is reconstructed. If you look at the different technologies, so we deployed 3-4 technologies. One was ASICON-based sequencing, another one was metagenomics-based next generation sequencing technologies with some capture probes, and we were able to identify 14 non-synonymous mutations, which means 14 mutations that change the virus protein in the RDRB. In the table below, we have just shown the comparison of these nucleotide sequences from the past Chandipura outbreaks from Nagpur and Andhra Pradesh. And if you just look at the phylogenetic analysis, where the person is standing, that is where the recent Chandipura outbreak virus stand is training. And we also checked it for the time-resolved phylogenetic analysis, and you can see that the virus that has been already sequenced, it has some mutations, but this is not as mutated as the SARS-CoV-2, which is rapidly mutating. So, these are just a broad glimpse. What I wanted to highlight here is that when you deploy technologies like next generation sequencing, it can give you a lot of information on diseases. Many times you can also understand many of the RT-PCR misdiagnosed cases. Also, you can resolve it with the NGS and other advanced technologies. And these are some of our collaborators with whom we have worked for all these infectious diseases. Thank you so much once again for giving me this opportunity to talk and discuss the work of GBRC in this forum. Thank you.
Thank you very much, Madam. It was wonderful information on the how WGS can help in controlling and diagnosing the infections. Any question?
I think it's too technical for everybody.
Many are the clinicians, so
Yeah,
it's a
that's
very
right,
difficult. But it's a wonderful session. Thank you very much, ma'am.
Thank you.
So now we are moving towards the next session, that is on the leptospirosis. And for that, I would like to invite on the stage Dr. Pratik Savaj. He is from Surat.
Sorry, just a moment, because Dr. Malvi needs to leave. We just hand over a token of appreciation. I request the chairpersons to kindly hand over a token of appreciation to Dr. Malvi for a wonderful talk on pathogens. Thank you very much. We can now move on to the next one.
So invite Dr. Pratik, please come on stage.
ASICON welcomes Dr. Pratik Savaj. Dr. Savaj serves as the Director and Infectious Disease Consultant at both Surat Clinic of Infectious Disease and Adult Immunization and IBCC Hospital. Dr. Savaj holds a DMB in Medicine, a fellowship in Infectious Disease, and an FMB in Infectious Disease. He also gained international experience through an observership at Harvard Hospital, USA. He is the author of the best-selling The Tasteful on Dengue Fever, has published research papers in national and international journals, and received the Young Achievers Award from the Association of Physicians of Gujarat. Dr. Savaj focuses on managing tropical infections, sepsis, HIV/AIDS, and adult immunization. He also conducts research on fungal infections and antimicrobial resistance. Through his leadership roles in clinical practice, Dr. Savaj demonstrates a strong commitment to providing high-quality care to patients with infectious diseases. We look forward to hear him talk on leptospirosis.
It looks like entry of superhero. So, sir, you said rightly, I am from Surat and so is Leptospirosis also. We both are from Surat. I was doing my R1 residency, DMB medicine. I did it from Venus Hospital, Surat in 2012. So I was posted in ER department and I saw one patient, 47-year female patient, acute febrile illness of 5 days, followed by breathlessness of 2 days. And she was initially evaluated out on OPD basis. On workup, there was a leukocytosis and thrombocytopenia. Create was normal, there was no malaria on peripheral smear. But on X-ray, you can say diffuse bilateral infiltrates. This was a time period of monsoon, and this is our differential diagnosis whenever we see any patient with a fever and respiratory illness. So dengue, chikungunya, malaria, typhoid, flu, rickets cell infection. These are the common causes of febrile illness from South Gujarat. On examination, she was tachypneic. There was bilateral diffuse scraps. My teacher asked me to add lepto IgM. Brief introduction of my teacher, who is a retired professor at civil hospital, and his name is Dr. Samir Trivedi, and he used to see 400 to 500 cases of leptospira post monsoon. And at civil hospital Surat, we have dedicated leptospirosis ward. So such a high intensity outbreak is seen in Surat post monsoon. The first lepto IgM was negative, but remember friends, this is a day 5 of illness. We did HRCT where you can see ground glass opacities and significant lung involvement. Now next day, her platelet count dropped further, create was 1.8, BLI was 4, and SGPT SGOT was 98 and 112. So I asked my teacher that how can you diagnose leptospira based on the history and basic blood report. So he told me, see Pratik, SGPT SGOT will never go more than 300. So it is the upper limit of the SGPT SGOT, but BLI can go sky high. So it is known as a disproportionate rise in bilirubin. That is the classic pattern of leptospirosis. So if you see all the tropical diseases, they have typical pattern, and if you understand their pattern, you can guess the cause. So she was put on NIV support, ceftriaxone with oral doxycycline was started. So as an IPD, whenever we see any case of hepatorenal pulmonary involvement, these are our differential diagnosis. Dengue, lepto, malaria, scrub typhus, hantavirus, and HLH. We have repeated her lepto IgM by ELISA, and that came as a positive. She required hemodialysis support for a few days, but gradually patient did well. So when I was doing my residency, we used to see daily 4 to 5 cases of leptospira, and the typical pattern is acute febrile illness followed by acute kidney injury, liver involvement, ARDS. So what is leptospira? We all know it's a zoonotic disease. So these are the animal, they often carry leptospira. They might be silent carrier or they might be actively infected. So what happens? They excrete leptospira in their urine, and this rice field, the leptospira can remain alive for weeks, for many weeks, and through the cracks on the leg, this leptospira can enter the body. So we all know the RRR, that is the rice field, rain, water, and the rats. So these are the occupational exposure. Those who run on the bare feet, they can get leptospira. Post monsoon, whether it's urban or rural, this type of scenario is seen, and that is the risk factor. Certain recreational activity is also known to cause leptospira. So if you go on holidays, please look for it. In Florida, 2005, there was a leptospira outbreak seen among the participants who took part in this water sports activity. In 2006, we had a very bad leptospira outbreak in Surat. Almost 80% of the city was affected with this leptospira. This disease has a unique presentation. It is known as a biphasic clinical presentation, where in the first week, when there is a phase of bacteremia, we see typical dengue-like illness. The only thing which can help us on clinical examination is a conjunctival sufficiency. And the second week, which is by the antibody production, which is associated with the organ dysfunction. So this is the photograph of conjunctival sufficiency, where you can see jaundice as well as subconjunctival hemorrhage. Weil's disease is the severe form of leptospirosis. 5 to 15% of the patients, they are affected. Hepatopulmonary renal involvement is a classic presentation, but it can go up to like myocarditis, even meningoencephalitis, pulmonary hemorrhage, rhabdomyolysis. So these are the common complications of the leptospirosis. Renal involvement is classic. As I said, that fever, AKI, and hepatitis. So what is the mechanism of renal involvement? The leptospira directly does injury to tubules. So there are two patterns, either acute interstitial nephritis or ATN, tubular necrosis. We have often seen the patient, they have a hypokalemia. The reason for hypokalemia is a tubular injury. There is a loss of potassium from these tubules. And most of the patients, they are non-oliguric. But it is said that if you put patient on early hemodialysis, it is associated with a good outcome. Pulmonary involvement, as I said, that it is seen in the second week of illness, and second week is an immunological phase, and there is an endothelial injury. Hemoptysis is seen in the 50% of the cases. Whenever there is a pulmonary involvement, there are so many papers, and few of the papers from my teacher, which has shown that if you give steroid within the 12 hours of dyspnea, it is associated with a good outcome. but data is limited. So many international papers are not supporting the use of steroids, so I think it is an individual call. Also, there is a role of IVIG and plasmapheresis. In India, one of the most common cause of death in Leptospira is the pulmonary hemorrhage, which is seen in more than 90% of the cases. There is a modified Fenton criteria to diagnose Leptospira, which includes lots of clinical features as well as the epidemiological factor, and you have to document with the laboratory finding. More than 25 is the suggestive of Leptospira. But now we are in the era of PCR. When I was doing my DNB, at that time PCR was not easily available. But now PCR is easily available. We are familiar with this tropical fever panel, which is a multiplex PCR panel, which also detects dengue, chikungunya, plasmodium, rickettsia, salmonella, and West Nile fever. The cost of this panel is around 5,000 rupees, and whenever we see any patient of acute febrile illness with renal involvement, lung involvement, or multi-organ dysfunction, we often send this panel, and we have found this panel to be useful. But this is a very important thing to understand, that you need to count the history of illness, that what is the day of illness. If it's within the 1 week, then there is a role of sending PCR. But if it's like end of 1 week or a patient is in the second week of illness, better to send antibody test. Either you can send IgM by ELISA or MAT. MAT is a microscopic agglutination test. But before the availability of PCR, we used to take small details from the CBC, the LFT report and CREATE report, and based on certain pattern, we can get initial clinical diagnosis, and we often use this chart. For example, in LFT, if you see SGPT more than SGOT with fever, malaria or viral hepatitis, you can consider. If SGOT is more than SGPT, then you suspect like dengue-like illness. And if you see alkaline phosphatase, GGT is high, and on CBC eosinopenia, then it is high likely you are dealing with typhoid. But if you see very high bilirubin, but SGPT, SGOT is normal or like less than the 5 times upper limit, then you should think about leptospirosis. There are various antibiotic regimen is available for leptospira. We have given penicillin. When penicillin was not available, we have given ceftriaxone, and for milder cases, we prefer doxycycline. In most of the clinical trial, all drugs are found to be helpful, and there is no one drug is superior to other drug. But right now, if we have to use, we use a combination of ceftriaxone and doxycycline. In any acute undifferentiated febrile illness, after sending appropriate investigation, again, ceftriaxone and doxycycline is the ideal choice of antibiotic. Prevention, those who are working in a high-risk environment, we ask them to wear personal protection, and rodent control is among the prevention. Chemoprophylaxis. So those who are involved in the high-risk activity like water sports, those who are doing flood, those who are exposed to flood water. So many papers have suggested that giving doxycycline once a week is found to be helpful, and it significantly reduces the incidence of leptospira. Thank you so much.
Thank you very much for giving wonderful insight of this leptospirosis. Any question? Yes, sir.
Wonderful talk. Just want to know what is the turnaround time of getting a multiplex in your place? How many days you get? How many hours?
Sir, we usually get within 12 hours.
12 hours. Yes. So in such cases, the empirical antibiotic will be started with ceftriaxone or doxy, or you wait for the result.
Sir, if patient is like hemodynamically unstable, then definitely after sending investigation, we can start immediately should start. But if patient is stable, like in ward, then we often wait for the PCR.
Lastly, very important is we have to give 1 week of IV antibiotic, not to have 5 days and followed by some more.
Yes.
The best results are seen with almost
IV.
7 days of IV antibiotic.
Continue IV antibiotic. Yeah.
Thank you.
Yes.
Thank you, Dr. Pratik. Just a little digression. You have a patient with an acute undifferentiated fever with no localizing symptoms. I agree with your differential diagnosis of the seasonal fever. But here, your predominant finding is tachypnea 32 and hypertension, desaturation, and X-rays showing these lesions. Why did you think in terms of leptospirosis? Because leptospirosis doesn't involve the lung, other than through ARDS. My thinking would be like it's like an influenza-like illness or influenza, which can mimic your seasonal fever. Or the next approach can be thrombocytopenia, fever with thrombocytopenia. Then all of your other differentials will work. Also look at, you had mentioned those 5 conditions where you do not have, you have changes in the SGOT, SGPT. Leptospirosis you don't have, which you have very rightly said. The reason why you don't have it is, it doesn't damage the liver.
Correct.
It is a causes only a dysfunction of the liver. That is why patients with leptospirosis will not die of liver cell cancer. They die of ARDS. Okay. One, because I don't want people, me also to go out saying that this was a case of leptospirosis. In order to prove leptospirosis, either you have demonstrate the spirometry, or you do MET 23 serovals, and the drug of choice world all over is penicillin. Ceftriaxone, doxycycline are all just our adjustments. Patient may respond, may not respond. So your case of 2012, what was it?
Sir, we at that point of time there was a outbreak in Surat. There was an active outbreak. Second thing, sir, we have sent MET test and it was also positive. We have repeated MET test after 1 week, which also documented the rising titer. And we at that point of time the PCR of H1N1 was available, so it was done, which was negative. And regarding, sir, we always prefer penicillin, but there was a shortage of penicillin during that point of time, so we have to use ceftriaxone.
Because okay, that's the reason why you use that.
Yes, sir. MET tests, sir, we always repeat to document the rising titer.
Thank you, Dr. Pratik. I think that was a good presentation. But we can also have lots of leptospirosis cases almost throughout the year. Because Kerala is not throughout the year. Now, one thing which we have observed is that either a positive test result for leptospira, which can be cross-reactive, or sometimes a previous infection, something like that, which most people are likely to have, or a negative result, practically never excludes leptospirosis. So, as Dr. Deep was rightly said, leptospirosis should ideally be a clinical diagnosis based on your clinical and other investigations. There is microbiological proof of leptospirosis many a time not needed if you want to start treatment. So if the patient is it's a clinical diagnosis. Ask clinicians who see leptospirosis rather frequently based on epidemiological features, of course, like the season and weather and it's something which you can go even without doing any.
Before PCR,
Totally not out about that.
yeah.
Thank you very much for a wonderful inputs by the senior members and Dr. Pratik for a wonderful session. It is not only considered you are from Surat, leptospirosis from Surat. Just want to add one more thing. Dr. Madhuri madam was talking about the Asiatic lions. She took the samples from the Asiatic lions. Asiatic lions, they are from Gujarat. And Savaj means lion. So this is also another coincidental. The lions both are from the Gujarat. Thank you very much for wonderful topic. The next presentation on the new worry zone in drug resistance. TB test kit. For that, I would like to invite on the stage Dr. Pratik Munif. He is also from the Surat. Please come on the stage.
ASICON welcomes Dr. Pratik. Dr. Munif is a consultant clinical microbiologist in multiple facilities in Surat, Gujarat. He holds an MBBS, an MD in clinical microbiology, and an MBA in healthcare services, demonstrating a strong foundation in both medicine and healthcare management. Dr. Munif is skilled in processing and interpreting various specimens, serological tests, microbacterial cultures, and molecular microbiology diagnostics. He has taught undergraduate medical, dental, and nursing students and has been recognized for his teaching abilities. Dr. Munif has published numerous research papers in national and international journals on microbiology and infectious diseases. We look forward to hearing him talk on New Horizon drug resistance TB testing.
Thank you so much for the kind words. I'll be taking you to the topic which is, I would say, it is always burning and very difficult to manage most of the time. This is my declaration. I'll be going through this topic under these headlines. The problem statement about the drug-resistant tuberculosis. What are the challenges in the diagnosis and management of TB? A clinical microbiologist perspective, and some case-based discussion about there is a lack of awareness about the availability of some molecular tests which are handled by WHO and AMS and diagnostics promotion, which is a burning problem. So before we begin, let us see where do we stand. I would like to quote a study of Dr. Vijaywada, which was done in 1991 and he repeated that in 2010. It was about the tuberculosis management by private practitioners in Mumbai, India. Has anything changed in 2 decades? So this was the study which had some sample questions. How do we manage? And when he repeated, he just added one more question. Please write about write a prescription for a previously untreated case of MDR TB resistant to INH and RIF, weighing 50 kg. There were 106 participants, 46 allopants, 60 others. 63 different regimes used, and only 6 confirmed with the standard recommended regime. MDR TB, only 5% correct, 13 continued first line, 25 left it blank, 35 read single drug. By looking at this study, me and my clinical pharmacist who are trying to implement AMS in my hospital, we tried to do this study among our clinicians. The data was so bad that I couldn't show here because the conclusion was we had more of endometrial TB than pulmonary TB because my gynecologists were treating tuberculosis. And when talked about cardiologists, all the pericardial effusions were being treated without being investigated. So that's the burden. So because of this, we can understand this is the national data. What's the problem? More than 69,000 estimated incidences of drug-resistant tuberculosis in 2023, 11,000 resistance to fluoroquinolones, 23,000 resistant to INH, 91% people started on second-line treatment from the beginning. So here is the quantum problem. Now these are some usual challenges which are faced in the diagnosis and management of tuberculosis. These are all real-life conversations or incidences, you can say. I'm practicing in the private practice. I don't have a big institute. So these are all real-life conversations I have put in. As soon as I have got a request for CBNAT, so I have called the doctor. Sir, CBNAT has come positive. Should I proceed for AMP culture? Because it was not asked. Did doctor? No. It's detected for the first time. No further workup. Second scenario. Sir, CBNAT has come positive. Should I proceed for AMP culture? Okay, go ahead. After 4 more weeks, sir, AMP culture has come positive. Should I go for DST? Doctor, leave it. The patient won't spend now. Workup stopped. Another scenario. Sir, first line DST, which was ordered, reveals MDR TB. Should I proceed for further tests, further drugs? Oh, let me call the patient. I'll ask the patient to do the formalities of further testing. Now patient doesn't come. So no further work. So this is the problem when it comes to growing TB, reporting, then asking for DST and so on. So here is a case. There is a 16-year-old female patient. She was diagnosed as Cox disease at the government setting in South Gujarat. CB9 on sputum specimen, which is done for free at the government setting. It showed MTB complex detected, leaf resistance not detected. She was started on first line AKT. Dosing according to the body weight, absolutely fine. After 1 month, she had massive pleural effusion, which was draining. Repeat radiology, it showed worsening of the frozen features. Now she consulted a pulmonologist at a tertiary care center. AFP culture was awaited at the government setting. Patient denied admission, though sick. Repeat CP9 was advised by the pulmonologist, let us see what it is. Cost constraints were there, but she got convinced at the end. CP9 on sputum, same result. Now pulmonologist still wanted to check if it was a monoresistance case of isoniazid. He asked us, should I add fluoroquinolones? I told sir, can we go for a test? I have your sample. If you can convince the patient for another test, we'll come to. We performed MTB XDR, which turned out to be monoresistance to fluoroquinolones. So if you see here, you can expect the unexpected when it comes to TB. Fluoroquinolones, if I think everybody will agree, it's the most commonly overused or misused drug in our country. Antimicrobial stewardship can be achieved with this kind of point of care testing. Going for another second case, these are all related cases you might have come across. In first case, you may feel that it can be TB, iris or whatever, but this is something which we found out in the workup. This is a case number 2. 18-year-old female with a history of coughing, weight loss, on and off hemoptysis. Father died of tuberculosis. There was no records with her. A sister was on treatment for the same under government hospital. Somewhat unsatisfied, so mother brought her to a pulmonologist. He advised, let us go for bronchoscopy because sputum was not satisfactory and bile was collected. Pulmonologist ordered, let us go for CB9 and AFB culture. It turned out to be MDR-TB. So he told that let us go for XDR-TB straight up. So this was the result. So you can see, we confirmed the diagnosis on the same day. It is kind of point of care. We could achieve diagnostic and antimicrobial stewardship, I think, which is the need of an hour. Everybody will agree because, as you know, that it is very difficult to go for the TB patient, go with the TB patient, sir, pay for the culture, then you pay for the DST and so on. So this is the impact of this test, which we felt and we have implemented at our place wherever feasible. So in many times, a pulmonologist uses it for detection of monoresistance to isoniazid or sometimes fluoroquinolones as well. And if there is MDR, definitely go for XDR. You will get the result, everything in 3 to 4 hours. So this is something which is reducing the diagnostic delay, which is quite common in diagnosing tuberculosis. If you go through the National Guidelines for Management of Drug-Resistant TB, the National Technical Expert Group, which is also recommending that you better go for this XDR panel once you have ordered the MDR for diagnosis and look for the resistance for INH, for fluoroquinolone and influenza. So this is what I would like to convey. Reflex testing should be offered to the patient well in the beginning, if possible. MTB XDR can be ordered if you have a culture growth. You have just ordered a culture, but now you don't want to go for the entire phenotypic DST and you are running short of time. So you can just ask your microbiologist that do XDR on this culture growth and you will come to. Phenotypic DST is definitely useful, but there is an unavoidable delay. And as you all might be facing that. Sequencing will take some time, lot of capital investment involved for the standalone labs, but definitely it is a way to go forward. And I feel AMS is a need of an hour. unnecessary starting all AKTs or unnecessary adding the reagents or modifying the reagents without testing, it is harmful. We are saying that. So, for all the microbiologists and clinicians here, communicate with each other what all things can be offered for a particular patient. Simply delivering the report won't help you out. You have sent something, add some test, do some permutation combinations. As I mentioned that if culture growth has come, just order XDR on that and see for second line there and there. Don't wait for the phenotypic DST. If there is a cost constraint, it will be a cheaper option rather than going for the entire DST. And last but not the least, this guy has a license to kill, we have a license to prescribe antibiotics. Let us use them judiciously. Thank you.
Thank you. Any questions, sir?
Sure.
First thing, when you see a patient with pulmonary tuberculosis, consider pulmonary. When you send sputum, what you send in your practice, directly CVNet or you send any other test? The sputum.
Sputum AFP. First it comes with sputum AFP.
Then.
And sometimes, if the patient is afforded, CVNet comes.
Okay. And will we get no refer resistant? Do we have to keep quiet or work for the monoresistance pattern?
We should actually. What we advise are at least send a culture. We'll keep a growth for particular time. And if you don't see the treatment response, you add DST or you go for the monoresistance.
I am a private practitioner, but in government sector, everything happens very systematically.
Correct.
There is SOP there.
Absolutely.
In private practice, as I showed in the chart, most of the people don't know. Even in the continuation phase, why 3 drugs are used, they don't know. They even try to use only 2 drugs now. The reasons, I think, they don't know. Right? That's a good thing. And CVNAT should be repeated the follow-up test. Ideally, they have been told not to repeat CVNAT test for follow-up. And third question is, when you do pleural tapping for CVNAT, in that case, it is very less. So in that case, we have to send the PCR or do pleural taps, whatever it is.
Absolutely.
Yeah, because it is not as a sputum.
Correct.
It comes down to 34% almost.
True, sir.
The sensitivity of it.
Yes.
That's what
That
happens.
stands true for all the body fluids.
Yeah. Now, in a private practitioner, as a private practitioner, you send for CVNAT, and whenever it is there, that is MTB gene expert riff. Otherwise, directly XDR when you suspect it.
Correct.
When do you suspect that means that?
Sir, if there is no contact, then you can go for it. Otherwise, first go for MTB riff and check for the fungus. And what we have observed in our setting, we are still evaluating, but we are finding that INH monoresistance is not so less, which is documented. I think it is more than that, because as you know that many patients are still under private setups where they are taking treatment. So as I mentioned, that evaluation doesn't happen. The diagnostics are not optimally used. You might have seen that.
Only I feel very bad that private practitioners are not trained, even though I am there. They are not trained to treat properly. Okay, that's one thing. We need more training. At least in my place, I am planning to do that more treatment.
Sir, can we move for the next slide? Yes, sir. Please, sir.
That was a great talk. A few comments. A lot of times for pulmonary TB it's fine. The problem is with extrapulmonary TB. Oftentimes what's forgotten is to send the sample in normal saline.
Correct.
And if the clinician doesn't advise sending the sample in normal saline and it goes in formalin, we've missed that one opportunity of detecting TB. And I agree with you that TB diagnosis and really classifying it is difficult. So just to clarify, irrespective of whether we suspect XDR or MDR or sensitive TB, the first test is definitely CVNAT for RIF resistance. If it is RIF not detected, which means rifampicin is going to work, we still go ahead and look for INH. In Mumbai especially, we are seeing INH monoresistant quite a lot. And if it is RIF resistant, then we send for XDR panel. It is an expensive test, but it is 100% cost effective because it saves you all the effort of giving a wrong treatment plan. And now, as a
part under the National TB Elimination Program. Both MDR and XDR are going to become available to everyone.
Yes.
In northern India.
Absolutely. Correct. Agreed. So what we have started doing is we are de-paraffinating that block, and we are following that xylitol process that to get the tissue back. But definitely it is still there will be a lot of papers that come up because of this habit of sending the sample informally. So we work on that formalin fixed paraffin block, and we try to get the deal. But definitely if it would have been sent in Chennai, this headache would not have happened. Yeah, that is, I'm not touching that part because it's with the government. So this is what we are facing in the private. That's what I wanted to say, that this is something which can be offered to patients.
Problem, Dr. Frenel.
Yes, sir.
Is that you finished your talk half time, 10 minutes left.
Yes, sir.
10 minutes left.
So I wanted to discuss with you.
Okay, so that's why there are so many questions coming to you.
Yes, sir.
Secondly, there is a difference between private sector and public sector.
Correct.
Now I ask you as microbiologist, search your soul and speak to the clinicians. Are you suspecting drug-resistant TB, mono or MDR or XDR? Perhaps the physician is not thinking. If the physician can also interact with you, Dr. Frenel, I am thinking of drug resistance. Why? He must say it's a florid case, or this person has been going on and had previous treatment.
Correct.
Then the pretest probability of it being drug resistant is high. So there must be some kind of an interaction. Second part is, as a microbiologist, when you find, when you get the sputum or culture, why don't you do these two also? INH and rifampicin as and plate it for your drug resistance profile. Because if you're doing the drug resistance profile as per your take-home message after the culture.
No, I'm just telling that if you want to save money on phenotypic DXT, if you just ask for culture.
No, your second take-home message was, show the culture report. The culture report takes 6 weeks.
Absolutely.
Yeah.
Yes, sir.
Then from there onwards to get my antimicrobial susceptibility pattern, I'll take another 6 weeks.
Absolutely.
For 12 weeks. So why can't you?
Yes. So that's what I wanted to convey, sir.
So you go ahead and for the microbiology lab, tell them that I'm going to put it for both and charge them.
Yes, that's what I
Sir.
wanted to offer, sir.
Sir, as for what we can do, I am also a microbiologist. What usually we recommend that the first you go for the gene expert, yeah, and I'm rifampicin and the culture, and after 4 weeks or 6 weeks, revisit the things, and at that time you have a growth, and with the growth you can do for anything. If you need to go for line probation, then you can have a good option because directly from the culture LPA good give good result. And if you can go with the DSP, and MGIT will take hardly 11 or 14 days to give the results. And yes, GNX, XDR also we can choose, but at least primarily, if rifampicin is sensitive, you should have go for culture and revisit your decision after 4 to 6 weeks. You can have multiple options, you can choose from
So
there.
once you have only sent culture, my message was, if you have sent only culture, then now don't go for DST, which will again consume your time. Just order XDR and your job will be done for the second year. That's how I wanted to save the time. That's all.
Maybe his message is very simple, that not only the expert but also the culture to be done from the beginning, and the next decision can be taken after 4 to 6 weeks. There are a lot of options, what we explain. Thank you very much. Now, next topic is also very important to discuss, that is antimicrobial resistance, and for that, I would like to call on the stage Dr. Pratik from the Mumbai, please.
Good afternoon. Dr. Gilada is a microbiologist. UNAIDS Diagnostics and Messina Hospital Trust. She is an infection control officer, Head and Neck Cancer Institute of India. Dr. Gilada received her MD in microbiology from Cape Hospital and further specialized in tuberculosis diagnostics through a fellowship at CAPRISA, South Africa. She is passionate about point-of-care diagnostics and infection control, aiming to improve rapid disease detection and prevention. Dr. Gilada actively addresses the critical issue of antimicrobial resistance in India and globally, advocating for effective strategies to combat this growing threat. Through her clinical and advocacy work, she demonstrates a strong commitment to advancing public health and combating infectious diseases. We look forward to hearing her talk on antimicrobial resistance.
Thank you. So I think after that important discussion on TB, a very similar topic about, in general, about antimicrobial resistance. I would like to do my talk the following points: antimicrobial resistance amendments, causes and the spread of antimicrobial resistance, where are we actually going wrong, and how can we rationalize the use of antibiotics. We know that antibiotics are being misused, and we now have data that over 50% of the antibiotics that are prescribed are either unnecessary or they are inappropriate. And the effect of that we are seeing is we see a lot of antimicrobial resistant infections in our ICU, which leads to almost 38% of infections in the ICU are because of multi-drug resistant organisms. It is being estimated that by 2050, if we do not do anything actively about antimicrobial resistance, it's going to be the #1 killer. So we're going to see about 10 million cases of death, which is very close to the number of deaths we are seeing due to cancer right now. So it's a problem that we all need to address like an emergency. We have seen a lot of antibiotics being developed over the years from 1900. A lot of antibiotics were discovered, and then within the next few years we saw resistance to those antibiotics. So since 2000 or say 2010, we actually have no newer antibiotics that are being developed because all our antibiotics have been now have resistance. And there are very few antibiotics in the same class of antibiotics that are coming up as new molecules, but we don't really have a new class of antibiotics altogether. So what we have in our pipeline is very, very limited, and we need to use it judiciously. We have also seen that in India, along with other countries, our prescribing patterns have become such that our antibiotic use from just 20 to 2015 has seen an immense increase. So it's almost double the amount of antibiotics that is being prescribed in that 15-year span. And also the prescribing pattern. So a lot of the antibiotics that we should actually be preserving for specific conditions are now being used as empirical therapy. Like what Dr. Fresnel also said, fluoroquinolones being used just for simple fever or just simple urinary tract infections, cough. So we are using those kinds of antibiotics we should actually be preserving for other conditions. So in India, we are seeing this trend at a much higher level than in other countries. And the ultimate result of that is we are actually seeing a lot of antimicrobial resistance even in our neonatal ICUs. So almost 190,000 cases of sepsis, and about 30% of these infections are due to multi-drug resistant organisms. It's an extremely sad situation as microbiologists, when the clinician comes up to says, okay, this is a newborn child, 5-day-old, comes up with a blood culture which is positive, and we finally give a result to the clinician saying there is only one antibiotic that we can all probably give this baby. So I think we all need to really take care of what we are going towards. How are we actually getting into this whole loop of antimicrobial resistance? So one is direct consumption of antibiotics that we all are doing. The other way is antibiotics are being used in our livestock, one for infections for these animals and also to increase yield. And all this is ultimately coming into our environment and also by human consumption of animals, that these antimicrobial resistant bacteria and antimicrobial resistance genes are circulating in the environment and amongst the humans. So finally, these multi-drip resistant organisms leads to threat to the therapeutics, leads to prolonged illnesses, very high medical costs. Again, because they are prone to infections, they are easy targets for other immunocompromised conditions. There is decreased effectiveness of drugs and very high mortality rates. So what can we actually do? Now, antimicrobial stewardship by itself is a very big topic, and I'm going to touch just upon a little bit of what we as doctors and clinicians and also as individuals in the community can do. What we actually mean by antimicrobial stewardship also has a lot of definitions. I'm just giving a very simple definition of it's just a set of efforts that we ensure that antibiotics are used appropriately and only when necessary, so that our ultimate goal is to have good patient outcomes, contain our healthcare costs, because obviously antibiotics lead to very, very high costs for the patients who are admitted in the hospital and in the ICU, and we minimize the unintended consequences, that is toxicities and obviously antimicrobial resistance. This is a team effort with the patient at the center. The clinician needs to have a good coordination with the microbiology lab, with a clinical pharmacist if they are in an institutional setup where a clinical pharmacologist can also be on board. The hospital administration, obviously, because if the institute has a policy of what should be an antibiotic policy and you need to step up in this particular fashion, I think it really helps, really use antibiotics only when they are needed. Awareness in the general population is what is actually needed. So just simple things like we have the World Antimicrobial Resistance Awareness Week, where we just talk to the general population of what they should not be doing as individuals, just going over the counter and taking medications, not completing the antibiotic course that is given to them. A lot of times using prescriptions that have been prescribed to them maybe a month ago or a year ago for a similar kind of infection. So just this awareness really helps. And what are the mistakes that we as clinicians can correct? So prescribing the antibiotics appropriately. A lot of times antibiotics are prescribed for viral infections, common cough and cold, where we know that giving an antibiotic would make the patient better in maybe 3 or 4 days, or actually not prescribing an antibiotic will still make the patient fine in about 3 or 4 days, because it's a viral infection and the antibiotic is not going to actually act. So we need to look at that does the patient really need an antibiotic for this condition? Understanding the organism, very important, because going back to our basics of microbiology, there are gram-positive and gram-negative organisms, and the antibiotics that act on both these organisms are actually a different set. There are very few that have a dual action. Most of the antibiotics are specific for gram-positive infections and specific for gram-negative infections. These are the common pathogens that we usually see. So the Enterococcus faecium and Staphylococcus aureus is the gram-positive group, and the gram-negative group, which includes the Klebsiella pneumoniae, Acinetobacter baumannii, Pseudomonas, other enterobacters with E. coli. And this is again, even our annual report talks about mainly the gram-negative infections that is more of a problem with our Indian setups even in the hospital and the ICU. And if you see here, this tells us what is the distribution of the organisms in the wards, in the ICU and in the OPD. We will see in the OPD, it's E. coli and maybe the gram-positive organisms, but in our hospitals, in-house and in the ICUs, it's the gram-negative which is a problem. So it's the Klebsiella pneumoniae, Acinetobacter and Pseudomonas, which is our major problem in the ICU. So what can we do in terms of understanding the resistance pattern? We need to know that every antibiotic has a specific target, and also the gene that it develops due to the resistance is also very specific. So we need to know this. I think more and more we are using antibiotics. We are also hearing terms which we've not heard before. We've probably heard only beta-lactamases. We now hear of ESBLs, AMCs, KPC, OXA, and the more antibiotic that we are going to use, the more information we need to have about these genes that are developing, because again with every kind of gene resistance, the antibiotic that needs to be prescribed is going to be different. What are the appropriate tools we can actually use so that we understand this better? Is like Dr. Fredan said, we need to have a good microbiology laboratory. We need to send cultures. So it's true even for general infections like urinary tract infections, where before an antibiotic is prescribed, it's best to send a culture to the laboratory. Obviously, our phenotypic methods are still there, where we take anywhere between 18 to 24 hours or something to about 48 hours to report along with a culture DST report. We now have a lot of molecular methods that are available, especially for TB, we have the gene expert. Also in terms of, I'll also come to where we are looking for carbapenemase resistance, we now have cartridges wherein once the culture is positive, we can directly look, I'll come to that once, where we can directly look at what are the genes for carbapenemase resistance so that the report can be available within 24 to 36 hours and we know what are the antibiotics we can actually prescribe. This is our conventional drug susceptibility testing, where we know that when the zone diameters are larger, we have an entire table where we look at what is the zone diameter, what would be susceptible and what will be resistant. Most of the reports now we do is on Vitek, which gives us the minimum inhibitory concentrations. But there are a lot of us which we probably do not know how we actually interpret these MIC values. So just giving us a brief about minimum inhibitory concentration is actually the lowest concentration at which we do not see visible growth of the organisms after a 18 to 24 hour culture that has been kept. So if we see here, 0.12 and 0.25 is showing a great inch. That means there's growth of organisms with those concentration of antibiotics. At 0.5, we see a clear circle. So there is no growth at 0.5 MIC, and that is our MIC for that isolate. Now, how do we interpret this in terms of the breakpoint? So breakpoint is actually developed with terms of hundreds or thousands of clinical isolates that have been studied earlier, along with their clinical outcomes, which help us get one number of a breakpoint, dividing it into the breakpoint below this is going to be sensitive. If your numbers are above this, it's going to be resistant, and if it's in between, then it's going to be intermediate to that organism. And how we use the MIC and the breakpoint together again becomes very important. So I'm just going to show you this culture report. This is usually a culture report, how we receive it when the patient takes. So this is a urinary tract infection wherein E. coli has grown, and there are antibiotics along with their MIC and interpretation. And probably a lot of times we would think that the lowest MIC is actually the best drug to give. So we would think maybe it's the ertapenem or the cefixime because it's got a low MIC. But that's not actually true. What we need to see is if it's a UTI and E. coli, our best antibiotics would be either reciprofloxacin, norfloxacin, or nitrofurantoin and fosfomycin. And if these are the MICs that we've got for these drugs, we know your ciprofloxacin is resistant because, like I said, we've used so much of fluoroquinolones in India that a lot of times we end up seeing fluoroquinolone resistance, UTIs, and also tuberculosis. So nitrofurantoin and fosfomycin would be our drug of choice here, and then we need to interpret this in light of our breakpoints. So breakpoints are provided by a specific guideline which we call as CLSI, which is fixed and it's standard used globally. So you interpret your breakpoint with your MIC with the breakpoint, and what we call is the breakpoint to MIC quotient. It's called a PMQ, where you interpret your MIC that you've got as 32 in light of your breakpoint, and you've got 2. So the higher the BMQ, the better is your antibiotic that's going to work. So it doesn't just depend on your MIC, it's also got to do with what is the breakpoint for sensitivity and resistance for that organism, for that antibiotic. I'm obviously trying to cover this in very short, but there's a lot we need to do in this. So we can discuss that. I think we can all discuss this with your microbiologists, that they will be able to help you with every report. Like I said, we now have carbamase detection cartridges using the same GeneXpert platform, which can be done on culture growth directly, so you would know which resistance pattern is present and prescribe the antibiotics accordingly. This becomes very important in cases of sepsis when patients are admitted in the ICU, because the treatment can be modified on the same day. There are other panels that are available, which is the BioFire panel, wherein again you would know which organism it is and what is the resistance pattern. Then we move on to giving the right drug, the right bug at the right site. So obviously it's the right drug in the right combination that needs to be prescribed. Like we said, the gram positives and the gram negatives, we need to see which antibiotic is going to work. We also need to see which is the site of infection we are actually targeting. Because like aminoglycosides are okay to use as monotherapy in maybe UTI and pyelonephritis, but should not be used as monotherapy in sepsis or in other bloodstream infections or abscesses. Again, tigecycline is not a very good drug in terms of UTI or bloodstream infections, but it's good for intra-abdominal or surgical site infections. Again, colistin should be used only for gram-negative organisms. For prostate, there are specific antibiotics. For central nervous system, we need to see whether the antibiotic is really going to cross the blood-brain barrier and then prescribe accordingly. Also, again, important becomes is actually controlling the source. So there are a lot of times we come up with surgical site infections where we know there's an abscess or we know there's a surgical site infection, but till we actually drain out the pus, giving how many days of antibiotics is not really going to help. So removing that source of infection becomes very, very important in some of these cases. And how do we really use this rationally? Well, you actually understand whether there is an infection. Do you really need to give an antibiotic? Which antibiotic are we going to give? What is going to be the dose? What is going to be the frequency? Do we need to give IV or can it work on oral? Because a lot of times patients are admitted and we are okay giving IV, but we really need to see if the patient is doing fine, is taking his meals orally, then it's better to just switch to an oral option. What should be the duration? We need to counsel our patients that please complete the duration of your antibiotics, because a lot of times resistance is also developing because they are not completing their antibiotic courses. And review and de-escalate. So once culture has been sent, we know that it probably takes about 24 to 48 hours to actually get a culture report. But once we have a culture report, do de-escalate or at least review your antibiotic prescription again. There are some drugs which have excellent oral bioavailability. So if possible, we should, like I said, we should be using those oral options than IV options. There are some drug combinations that are freely available, but they really don't work that well. So we really need to see whether these antibiotic combinations are making sense for us. we should ask our institutions and our laboratories to provide us with antibiograms. We now have national antibiotic policy, but every institute should have their antibiotic policy of their own, where they know what is their commonest organism for a particular infection and what is their likely resistance pattern and which would be the likely antibiotic they would prescribe in that situation. Other infection prevention and control practices become extremely important, because if we can actually prevent our infections in the hospital and in the community, our use of antibiotics will reduce. Vaccination is important, because if we know that we are vaccinated, like in cases of typhoid, influenza B, our need for antibiotic will anyway reduce. So my take-home message would be microbiology guides therapy whenever possible. Indications should be evidence-based. We need to use the right drug, the right bug at the right site at the right time. We promote effective patient awareness, because that will go a long way if we actually make each of our patients aware when we are giving them an antibiotic. Infection prevention and control practices, and advocate adult vaccination along with what we are actually doing for pediatric age group. Thank you so much. And like I said, I think we all have promises to keep and miles to go before we sleep. Thank you.
Thank you. Wonderful presentation. Dot in time. No one more second, no one less second. Yes, the question.
Good afternoon, everybody. I think this is the best lecture I've heard. Even though as a medical teacher since last more than 40 years, but you have tried to cover almost everything about audience wants. Now we come back to the baseline of the program. We can divide the clinicians into 3 different areas. One, a corporate hospital clinicians. Second, a government hospital clinicians. And the third, the biggest major criteria are the small scale prescribers. From small villages to small towns. They have no rules for them. The one thing which I want to point out is the hurdles in implementation of antimicrobial stewardship. You think about the hurdles, what hurdle we are facing? I worked as an infection control in a government hospital for more than 15 years as an infection control, 10 years in the private hospitals, and now with the corporate hospitals. Now the hurdle, what is the biggest hurdle? Biggest hurdle of implementation of antimicrobial stewardship. The one point, just I will not discuss everything, only one point in the stewardship program is the prescription audits. Who is doing prescription audit? Anybody? And when you start doing prescription audit, clinician has a very big rejection to the microbiologist. Who are you to ask us? We have no time to write. We have no time to discuss. We are very busy people. Second, the hurdle is the VIP syndrome. It is not written anywhere in the book. If your patient is the son of a minister, you will give antibacterial, antiviral, antifungal, everything. Nobody will ask you that why you have not prescribed it. Your brother is there, your brother is there, your prescription style will change. Third important thing in this is the legal consequences. People think that if you don't prescribe, somebody will ask that why you have not prescribed. Because you have not prescribed, patient died. You are responsible. They don't think about this stewardship program. There are some more are there, but just I want to start thinking about the implementation of the program practically in every area of the treatment. Thank you for a nice answer.
Thank you very much. Please.
Wonderful talk. I really enjoyed it. I just want to know, before getting the culture report on the hand, microbiologists can see, visualize what is happening in the dish and expect that some organisms are growing. I think daily discussion whenever it is needed with the microbiologist or a pathologist is a must for a good clinician to see. And if we see about 50 patients, at least 2% of the patient doesn't require any medicines. At least 10% of the patient doesn't require any antibiotic.
Yes.
So what we teach your students is what not to be written. If a good physician, then don't write unnecessary antibiotic. And as they are told, we have to monitor the prescription papers, then only we come to know what is
So it's because it's become so much of awareness, even the patient knows. The patient will ask, आपने antibiotic नहीं दिया, आपने antibiotic क्यों नहीं दिया? So I think that prescription thing audit needs to come from us, that you don't need an antibiotic for this condition and you will be fine in 3 days anyway.
Yeah, one more thing, when we see the antibiogram report, culture report, and many will be given, to choose which one is very important. But some of the people will give this is the priority wise, but they don't know what infection is. That is also very important.
Actually, catching on from what you were saying, from the undergraduate days, I think we have to avoid telling our students about treatment of urinary tract infection, treatment of pneumonia, treatment of UNAIDS, etc. Rather, we have to tell them treatment of E. coli infections, streptococcus infections, streptococcus infections. Even now, students are taught what is the drug of choice for UTI,
yes.
what is the drug of choice for meningitis.
But for what organism, yes.
Unless they know which organism is there, and we have to be very, very specific that this is an antimicrobial organism, antimicrobial chemical that they are using. So that concept must go into this. And the second, of course, is regarding the use of antimicrobials outside the medical field. Practically no control over that. So much so we have, in one of our meetings, somebody was suggesting if you get fever, don't take antibiotics, take chicken.
Thank you very much. Last question.
Can I just ask, why are drugs so freely available in India?
Yeah, so the regulations
I collect medicines, antibiotics, and take them with me to England. So how come? Why is it that drugs are so
our regulations need to be
Yeah,
very strict in terms of providing over-the-counter.
Isn't that the problem?
Yes, it is.
So what is the medical fraternity doing about ensuring that something happens somewhere, regulations are put in?
Antimicrobial stewardship program already being implemented in some states of our country, and almost 4 states are implementing very nicely. The Gujarat has just started this program last month, and in that case, right now we are just educating. And since 2 years, the WHO World Antimicrobial Awareness Week, the WHO is targeting the public awareness as well. So now public will start asking why you are giving antibiotic to me. Not only that why you are not giving, but they can also ask why you are prescribing this antibiotic to me. So this already going on. Still there are many hurdles, but will work. Gradually it will work. I think we can conclude the session.
Kerala is one state where antibiotics are not available over the counter, even for people like us. If I go and ask for antibiotics, they will not give. And there is absolutely no refills for antibiotics. That has been enforced strictly in the state.
Yes, I think that states need to take that up as
Thank you very much. So it was a wonderful presentation, and now we can end this session. Thank you very much.
Thank you to all the speakers for sharing their insights and of the chairperson.